So I'm talking about kind of acute behavioural disturbance and psychosis, which is a huge subject and something that is kind of continuously evolving, and we're learning huge amounts about as well. So I was trying to think about trying to give an overview, but also trying to make it more relevant to, I guess, paediatric trainees and what you might come across and be asked to kind of be aware of. And I guess my kind of take home from what I'm hoping to get from this is that there would be a kind of, is to help you feel more open-minded when you see a patient presenting with a kind of acute behavioural disturbance or symptoms that might be suggestive of psychosis. So that, because of course most of the time it might be a kind of functional psychosis, but there are other organic causes that need to be thought about, and I wouldn't want them to be missed, because if they're kind of potentially reversible or even you know, kind of dangerous disorders that could be treated, then that kind of needs to be focused upon. So that's my kind of hope from today, that we can think about all of those you know, differentials, I suppose, to a certain extent. But before I start, it would be helpful just, I don't think there's enough time to do introductions, but if anyone has a kind of burning desire, something they really want to get from this talk, then please let me know, and I can try to kind of include it if it's not included. So either in the chat or, you know, speaking would be great. And this is going to be a bit interactive, so you might as well get used to it now and ask some questions.
I guess, Megan, I have a question. Which just comes from my own experience of these sort of situations in the ED, which is just some tips on how best to advocate for patients where they are awaiting placement, or you know, end up physically being stuck for days or even weeks in the ED, which clearly is not good for anybody, least of all the young person. So how best, which channels to use and how best to advocate for those young people?
What, once there's been a kind of clear diagnosis made, and
yeah. So that's, so yeah, exactly, later down the line.
Yeah, and then I can just see Chantel's also asked about medication, so that's there. Okay, so I hadn't put about the advocating, because I guess that sort of depends a little bit on what's happening, you know, what the cause is, I suppose. But yeah, I can try to come back to that at the end, because I think that is really important. Okay, so so if we move on to the next one, I forgot it's not me, is it? It's doing great. So overall, what I want to kind of think about is important aspects of a history when you're seeing someone presenting with kind of concerning behaviour or things that may be suggestive of psychosis, what kind of physical examinations you might want to think of, some investigations, some possible differential diagnosis, and then some treatments, which of course will, I suppose, be dependent on what the cause is. So, okay. So to help us think about this, I think I wanted to use a case. So if we can go to the next slide. Yeah, so Chantal, behavioural disturbances that are not, I do cover that a little bit. Yeah, okay. Fine. So if we can, so basically this is a case that I've made up. This isn't true, but it's essentially a 16-year-old boy who presents with his parents to the emergency department, and they're concerned about his behaviour. He's been increasingly withdrawn. They've noticed that he's pacing at home, and that recently he's been saying some kind of concerning things like that his mum's not real, and so they kind of felt that they wanted him seen because they didn't know what was happening. So what would you want to know? If you saw this person in ED and you were the first person to see them, what information might you want? Again, you can write it in the chat if you want. Yeah, Emma?
I'm going to want a really detailed history of how the behaviour evolved, like over how long, what was the first thing that happened, and just kind of just have a little bit more information about how it's come about. Because that will really help me to distinguish between the things that come on more acutely and the things that can come on more over over time.
Yeah, so exactly what kind of led up to it, the kind of current circumstances, and what other things. Oh, any hallucinations, Matt's saying? Yeah. The length of time, pre-morbid functioning, precipitating factors, yeah. And anything else?
Has he taken any drugs?
Yeah, so any recent life events, Andrew's saying, any drug taking, yeah. And I guess with drug taking, that would be both kind of illegal stuff, but also what medication is he on? Because some medications do have this as a potential side effect or could be causing kind of physical health aspect. Yeah, Chantal, so physical symptoms, fever, social history, the kind of family makeup. Himat, what's headness? Do you want to tell me about that?
I think that might be referring to the heads, heads doing an adolescent health, sort of holistic adolescent.
Yeah. So heads is very good. Again, it kind of goes through all of those things, thinking about triggers, thinking about education, thinking about kind of sexual activity, abuse, and it is a good overview of kind of what's been happening for a child. So that is a good one. Okay, next slide, sorry. So, and then press again, and again. So yeah, so exactly kind of what you guys were talking about. So what's led up to it, the current circumstances and those current symptoms, any recent illnesses, particularly fevers, head injury, seizures, any change in movements or regression or change in behaviour, headaches, past medical history, particularly focusing on kind of autoimmune aspects, family history, social history, and as someone else was saying, kind of significant trauma that might have happened or kind of recently happened, and drug use, and then of course kind of risk to self or to others or from others. So if I give you a bit more information, this boy had been smoking, his mum and dad knew that he'd been smoking cannabis, and he'd become increasingly withdrawn, particularly during lockdown, so he was spending more and more time in his room. He'd recently stopped showering, he was eating sometimes but becoming kind of increasingly more suspicious, particularly if he knew that his mum had cooked it. He'd increasingly not been sleeping, so he was kind of pacing up and down during the night time, and although his parents, he would stop if his parents asked him, he would then start a few hours later, and has made some concerning comments about his mum not being who she says she is, and pretending to be her, and someone else pretending to be her, and that kind of alarmed them, and that's what kind of brought them into A&E. And they have noticed that he's sometimes whispering to himself. They haven't noticed a recent head injury, although when he was about 10, he did fall from a kind of first floor window. He hasn't had any seizures. He does have headaches, and they have perhaps been a little bit worse. No current COVID symptoms, no clear movement changes, although some agitation, no loss of skills or kind of aggression, and no recent travel. And I guess stressful life events have been happening. So he was bullied before lockdown and finding it increasingly hard. And lockdown, of course, is a stressful life event. In terms of their family history, mum has anxiety and aunt had one episode, a psychotic episode, where in the past when she smoked cannabis, and mum has thyroid disease. But other than that, no kind of significant family history, apart from a grandparent that kind of died suddenly at about 50. Socially lives with mum and dad, and was quite stressed at school, but does have some friends, and the only drugs that they know that he uses is cannabis, and no kind of significant risk to himself. So, next slide. Now what? What would you want to do now? Once you've spoken to parents, that's all from parents. Physical examination, yeah.
And speak to him himself.
Speak to him, yeah, exactly. So, oh, no, sorry, it's not me, is it? Can you do the next slide? So exactly, so the first thing you need to do is speak to the boy, because of course that's the parent's view, but he may have a completely different view. And of course, speaking with him will allow you to do a mental state examination, even if you can't get all of that information, just observing him and seeing him will allow for it. So he is able to engage in quite a good conversation. He's pacing up and down, and he's sort of asking where he is and says he wants to go home. He mentions that he thinks his parents have been captured and that someone else is pretending to be his mum, and he doesn't trust them, and so he's spending a lot more time in his room. He's thinking about running away and trying not to eat things that she's given him. He says that he's not hearing a voice, but certainly you see that he's kind of more distracted and kind of laughing incongruently at times. He does remember having a kind of headache and does describe that those headaches are there every so often. And he says that he's willing to stay in hospital as long as his parents, particularly his mum, doesn't stay. So, and in terms of a physical examination, what things might you be focusing on most? Of course, you'd want to do a kind of full physical examination if possible, but if that wasn't possible, what things might you be kind of really focusing on? So I suppose I'd be thinking of a kind of neurological examination, because you'd be wanting to see if there's any abnormal, signs of intracranial hemorrhage, exactly. And so you'd be wanting to see if there's kind of any abnormal neurology that might suggest something, a space occupying lesion, a bleed, an encephalopathy, anything like that. And and again, if he's orientated to kind of time, place, and person would be quite important. So again, physical examination, sometimes people will allow you to do that and sometimes they won't. But most of the time, if you kind of manage to make someone feel calm enough and they know where they are, then you can allow some physical examination. And I guess at the very least, what you can do, he's pacing, you know that he's moving all four limbs. You can look to see if there's any tremor, if there's any other abnormal movements. If he looks jaundiced, him like you're saying, liver disease. If there are any mannerisms, which gives you some information, I suppose. Not everything, and of course an examination would be vital, but it might allow you to have a bit of kind of start. Okay, so let's move on. So as we said, complete mental state, a physical examination, and then you'd be wanting to think of bloods, and I guess he's likely to need an admission because at the moment he doesn't want to go home with parents are kind of concerned about things, and actually there's enough concern that we need to be thinking about what is kind of going on here. And you'd be wanting to work alongside CAMHS, and I think right from the beginning you'd be wanting to be working alongside someone from CAMHS to get some advice on what sort of assessments might be useful, but also then to help you to think about, does this feel like a more psychotic presentation or more of a kind of functional psychosis or more of an organic state? So this is when kind of working together is the best. And I guess, Catherine, going back to that kind of advocacy, that's when it's about, if there are kind of both PEDS and CAMHS working together to try to advocate for that patient to get the kind of best care possible, it works better than if it's just one or the other, or you're working against each other. So, so that I suppose would be my answer to that advocacy question.
And thanks. Yeah. That's really helpful. That's exactly what I meant. I guess in places where I've worked before, unfortunately, the medical team have had to confirm that a patient is completely medically cleared before CAMHS will get involved, and I think that's, I don't know, I guess a bit of a shame. Do you feel like there's a movement away from that sort of model of?
I think there is a movement. Sorry.
Away from the model of sort of sequential team rather than cooperation.
I think so. I mean, I suppose there should be, and most of the time we would be working. I would always be working alongside. I suppose there is some stuff that it might be that you want to prioritize some of the physical health stuff over seeing CAMHS first of all. So, if they've got if they've got a head injury or something, you'd be of course wanting to prioritize that physical health assessment rather than waiting 3 hours for a CAMHS doctor to come in. But I think working together is increasing like that. Certainly where I work, that's what we do, is that we would work together around this. We wouldn't be waiting one or the other.
That's great to hear. Thanks.
Yeah. Okay, we can move on to the next thing. So what's our differential diagnosis at the moment then? Obviously, we've only just started, but we need a differential to then think about what investigations we might want. And this can be as broad as you like, really. Yeah, so again, a drug-induced psychosis, first episode psychosis, yeah, both of those could be. Autoimmune encephalitis, yeah. So we've got a bit of an autoimmune history from mum, so that could be something, you know, that he could have. Yeah, so we want to rule out Wilson.
Yeah, with the history of headaches, and the headaches increasing, I might want to think about, I don't know, whether we need to do some imaging just to rule out like a space occupying lesion, although I guess it's fairly low likelihood.
Yeah, I agree. All of this is relatively low likelihood, but I agree. I think with headaches, you kind of have to not, you know, you have to be listening to that and thinking about the fact that they've been increasing and certainly changing, and thinking about imaging. Yeah. Great. So that's relatively similar. Oh, sorry. Can you do the next slide? I was just about to do it again. So it's exactly that. I think drug-induced psychosis kind of seems the most likely as a kind of trigger, although it's been going on for quite a while and we don't know whether he's stopped and started his cannabis or whether he's just been smoking throughout. Epilepsy seems less likely in this situation, but you do sometimes have it where people will have unusual experiences that then lead to a seizure, or you know, post-ictally, someone can present with psychotic symptoms after a seizure. So encephalitis, you'd be thinking autoimmune, infective. And the other thing, just really, really important to think about at the moment with COVID, is that about 30% of patients, there has been seen to be evidence that in about 30% of patients, was it that much? That's quite a lot, isn't it? A certain proportion, anyway, of patients with COVID have had neuropsychiatric symptoms, including kind of psychotic phenomenon. So it's important, as we know, it's presenting in so many different ways, that it would be helpful and important to think about that. And certainly coronaviruses in the past have been associated with kind of encephalopathies. So it would be important to focus on that, particularly as we know some people are asymptomatic. I guess the other things are, you know, space occupying lesions, a bleed, and DKA. Going back to what someone's comment, I can't remember who it was, right at the beginning, Chantal maybe, that said about ASD, and I suppose these two at the bottom seem much less likely from this history, but you do sometimes have people with ASD that can kind of misinterpret, I suppose, their internal voice, or have slightly unusual experiences like imaginary friends and things that might be perceived as kind of psychotic phenomenon. And so that's sometimes a differential diagnosis to kind of have in the background if that's thought. But again, that would need a very clear assessment to know that. And that other people may have pseudo hallucinations, which is a kind of internal voice that is often kind of mood congruent, negative about them, and often they know that it's a voice and it's their own voice rather than an external voice that they're kind of have no idea and think it's a real person. So that's some of the differentials. As we know, there's a huge number of differentials, but that might be some of them. So in terms of then blood tests, what would you then want to do? Because I guess what we want to do is start with the least invasive, because if he's agitated and worried, then, you know, bloods would be easy to get, whereas other things might be slightly harder to get. So what blood tests would you want to start with? Sugar, yeah. So there have been occasional times when DKA has presented with kind of psychotic phenomenon, LFTs, and that's, I guess, really helpful for Wilson's, yeah, blood gas. Yeah, bone profile, calcium, yeah. Yeah, so FBC, TFTs, and the FBC, I guess, would allow for a bit of a screen in terms of infection. And yeah, using TFTs. So, okay, if we move to the next screen. Yeah. Oh, sorry, and then, yeah. So as we said, a kind of, infection screen, using these LFTs, if there is kind of any concern about Wilson's, thinking about those, endocrine, TFTs, glucose, and then autoimmune things, anti-NMDA antibodies, ANA antibodies, and of course all of these take a while to come back, but are important to do. And urine toxicology, someone mentioned that earlier, and particularly because he's been smoking cannabis, it would be important to kind of know if there's been anything else that he's been taking, or if it's just cannabis, and that also might be able to show a little bit about when the last time was that he smoked cannabis, because if it's not in the urine, then it's probably a couple of days ago. Okay, so then let's go to the next slide. Anything else? Someone before was just saying an LP if not contraindicated. Why would you do an LP? Yeah, so Himat's saying to diagnose encephalitis. Yeah, and I agree. So some, before Catherine, I think, was saying some imaging of some sort, I think particularly because of the headache and worsening headache. So I would particularly, often in a kind of first case psychosis, I would be thinking about imaging, really, because it's relatively easy to get. And it's important to kind of make sure that we're not missing something that is potentially life-threatening or potentially reversible. But I guess the anything else ones are ones that I would be wanting to, yeah, an ECG would be good. I would be wanting to kind of discuss with CAMS to think about, should we be doing this, and what's the safest way to be doing kind of MRI or LP. Someone else just said ECG, and I agree that is helpful, particularly if you're thinking of starting medication later on. And then anything else, something that female pregnancy test, yeah. And one other thing that I kind of just spoke about that's quite easy to get. And it's very...
COVID test, or?
Yeah, COVID test, exactly. So COVID test is also important. And yeah, Himat blood pressure would be good. So let's press the next slide. So yeah, so these are all ones that I'd be considering, and it would depend on the presentation, the kind of history, the kind of physical examination. But I suppose I would err on the side of caution and be more likely to at least image ahead, just to make sure that there's not something there. And but again, that has to be thought about as both a paediatric and CAMS team together. And as I said, with COVID, there is increasing evidence that people present with certain neurological symptoms and encephalitis, so it's important to just kind of have it, and it's relatively non-invasive, so it's worthwhile doing if possible. So I'm going to go to the next slide. These are you don't need to look at this really, but this is the kind of slightly more unusual ones that say if there was something on examination or on the history that, they just traveled somewhere, then you might want to be thinking about, that has malaria, you'd be thinking about malaria or TB. If they've been bitten by a tick, you'd be thinking about Lyme serology. And if there was more of a kind of, if you knew that they had, kind of neuroblastoma or other things, that you might be then looking for slightly more unusual antibodies. But I think by the time you're getting to any of these, I'd be wanting kind of very specialist advice from a neurologist and a psychiatrist, because these are all unusual tests that, you might want to make sure that you're kind of taking in the correct way to make sure you're not missing anything. So we can skip on from that, but I just thought I would say that there are lots and lots, there are more than that, lots and lots of tests that can be done, and obviously we can't do all of those, so it's about exploring those with specialists. Oh, sorry, back one. What is it? Oh no, so actually no, sorry, it is one. Sorry, next one. So this one is just to help you. This was just a really recent paper that I just saw that is mainly based, I think, on adults, but I think it would be relevant to children as well, that just helps us to think a little bit more about, because I suppose we're always wondering, are we missing anti-NMDA encephalitis more? Should we be thinking about it? And I suppose they put together quite a helpful list of things that make you more likely to think that it's anti-NMDA encephalitis. So if they have these symptoms, then you'd be really thinking we need to kind of do a full assessment, and again be speaking with a neurologist and someone that has kind of specialist experience around anti-NMDA encephalitis, because the tests sometimes, you know, take a long time to come back. So it'd be important if you get any of these sorts of ones. So, you know, we have had in this boy a change in headache pattern, so it might be worth, for this, considering speaking to, you know, for this case, considering speaking to a neurologist or someone with kind of specialist knowledge around this to consider what else, you know, whether we should be treating for it. So I thought that was just quite a helpful list, really, to have there. Okay, we can move on to the next one now. So once he's been admitted up to the ward, what sort of things might you want to do on the ward to help him? Remembering he's going to be really scared, he doesn't really know where he is necessarily, he doesn't have his parents with him, which he doesn't want, but equally that's quite scary, it's a new place. Yeah, so getting a play specialist involved and consider the best environment on your ward. So what might be the best environment? Yeah, cubicle or side room would be best, really. And something about continuity of carers. Yeah, so you're not constantly having to, you know, introduce him to a new person. And also, if there's continuity, what that allows is then to understand if he's deteriorating or getting better, because they will have built up some kind of relationship. Okay, next one. So yeah, so as you were saying, being in a side room, trying to get someone he trusts. So even if his parents can't come, is there an aunt or grandparent or someone that could be with him to help him feel a bit calmer? Try to allocate the same nurses or limited numbers of nurses with him. Try to there not be too much noise and have kind of careful observation of him and really explain things. And you might have to explain things a number of times, because depending on what he's experiencing, he might find everything very confusing or not know exactly what's happening. And I suppose the other thing is that he's pacing up and down in A&E, and I suppose people can rightly be a bit concerned about that on a paediatric ward. But I suppose my view is if he's in his cubicle and he's not trying to hurt anyone and it's just his way of kind of managing his difficult experiences, then it's okay for him to pace. And sometimes him sitting down in his bed and being made to just sit might be very, very distressing and be harder for him in lots of ways. So I suppose that would be a team discussion to think about, and the safety around that. But if that was safe enough, then I think allowing him to pace would be, you know, might be helpful. Okay. The other thing is, someone was asking earlier about medication, and I suppose I would always err on the side of caution with medication. I think most of the time having a really good environment, good verbal de-escalation, you know, and good, you know, nursing staff around him will allow him to feel kind of comfortable enough. I suppose if he's getting to a point where he's a risk to himself or to others, then, you know, each place will have its own kind of rapid tranquilization protocol, and so you'd have to be utilizing that. But you also need to be thinking, under what grounds are you giving this? And if he's not willing to accept it, then you need to be thinking, well, how am I giving this legally? And so there just need to be some kind of thinking around that. I suppose most places would say lorazepam is quite a good option, but sometimes people have this kind of paradoxical reaction where they get worse. Promethazine is a good one. Again, antipsychotics, I try to avoid utilizing them acutely because you want to try to get an ECG beforehand. This boy has had someone in his family that died, before 50 of sudden death, so they might be a kind of risk factor there that's going on. So it would be kind of best not to. I suppose the one thing just to think about, which I'll come on to, is that sometimes people with anti-NMDA encephalitis, it was in previous slides as well, do have this kind of abnormal reaction to antipsychotics and can get an kind of autonomic response where their blood pressure and pulse rate and temperature goes up and down, and even get kind of neuroleptic malignant syndrome. So it's important to just bear that in mind, that if you do think that they may have that, then utilising antipsychotics might not be the best option to begin with. So, next slide. So is there any questions about the medication? Because I guess people wanted to think about that. We can come back to it afterwards.
Is there anything we should be aware of, to sort of cautions or things to look out for when using promethazine?
Well, promethazine is just a sort of antihistamine, so you can only use within the certain doses, but most of the time, most people will have tried an antihistamine in the past at some point, so it's quite a good one because you can say, did they have a reaction? But no, I don't. I'd look through the side effect profile and talk it through with the parents and with him, but not to my knowledge. Is there something that you're thinking of? Because I don't.
No, not at all. Thank you.
But I guess it is important when you're utilising medication to involve the parents and the child within that as well, the young person within that, because them understanding what those side effects might be. Yeah, so exactly, as you say, in terms of lorazepam, you need to check that there isn't a kind of reason not to give it as well, because not only can you have this paradoxical reaction, it may be that it would sedate you too much. So if you've got breathing difficulties, so we've got hepatic encephalopathy, all of those things are going to kind of exacerbate it and make it much worse. So be careful and make sure that you're thinking much, carefully about utilising medication. And that's why I'd use it as a last resort, because every medication has side effects. And, like I say, verbal de-escalation is probably better. So I guess I wanted to kind of put it out there, which is that, say he wanted to leave, what would you then be thinking about in this situation? Yeah, risk assessment. But we already know, I guess, what he's said so far is that he has thought about running away, that he's not eating the food of his mum and dad. His mum and dad are kind of concerned about him going home because he's not eating as much, and he's been saying worrying things about his parents. So you've got a bit of a risk assessment, but yes, I agree, a risk assessment at this very moment would be important.
Do you want to think about a capacity assessment, because he's 16, right?
Yeah, exactly. Yeah, so 16 and above, you've got a capacity assessment, and you'd be wanting to think about, does he have the capacity to know where he is, to understand the, the kind of pros and cons, weigh that up, and to be able to then communicate what's happening. And particularly around, because at the moment you're kind of investigating for a physical health cause as well as a kind of psychosis, then any investigations that are being done would be, and if he's refusing them, would then need to be thought about in terms of capacity, I suppose, because that would be part of it. So that's one thing as Mental Capacity Act. Sorry, SJN, you were saying the reason why, as in the reason why he wants to leave. Yeah, exactly. Just exploring why he wants to leave. Sometimes it's as simple as, and wants some food, and someone can go and get him that or whatever, like exactly exploring why he wants to leave is really important. I agree. I guess, has anyone else got any other options of what you might do if you wanted to leave? Capacity Act, I agree, would be really important. Someone was mentioning risk, and he's on a ward. So you could potentially think about a section 5.2. Oh, sorry. He has capacity but still concerns, and he's on the ward. There we go. Yeah, exactly. So you could think about a 5.2, which is just a kind of a 72-hour holding power that would allow for a further full CAMS assessment to consider whether, he was kind of safe to leave or not. And, probably with him, with this patient, they may well be considering, whether a section assessment needs to go ahead, depending on why he wants to go and how they can manage him. Yeah, so in A&E it is much more difficult because you can only 5-2 once they've been admitted onto the ward, so it is more difficult, I suppose. Children Act means you kind of have to make sure police can bring them back as a 136. So yeah, you can, and actually police, I think you can section 136 within an A&E environment, but police don't like doing that, but it's technically a public place, so they can. And also, you'd be kind of thinking about the Children's Act, that this person is very, very vulnerable. So maybe, and again, he may not have capacity to make that decision, so you might be thinking about that. So again, if someone wants to leave, this is when you'd be escalating to your registrar, to your consultant, to CAMS, to be thinking about whether it's safe for them to leave or not, and what you can do to kind of help with that. So none of these decisions need to be taken immediately, and they should all be kind of escalated as soon as possible. But it is much more, there aren't as many kind of safeguards, I suppose. You can't utilise a 5-2 when they're in A&E. Okay, so let's move on to the next slide. Yeah, so that's just saying the same thing. So in terms of treatment, I guess it depends on the cause. If there's a clear kind of physical cause, then you'd obviously be wanting to treat that. And most of the time, treating early will improve prognosis. The longer you leave it, the more symptoms they develop, and the harder it is to kind of reverse or prevent it kind of preventing them relapsing again. Anti-NMDA encephalitis, you'd be wanting to seek, if we think it is, or they have those kind of red flag symptoms, then you'd be wanting to seek specialist advice really around that. Most of the time, the treatment, I think, is kind of steroids and IV immunoglobulins and stuff, but I think before you did any of that, you'd be wanting to know what those doses are and be speaking to a neurologist around that. And as I said, just to be aware of potential negative reactions to antipsychotics in people with anti-NMDA encephalitis. Okay. And then, of course, if we've got a functional psychosis, so if we think actually we've ruled out most of the organic causes, we think it's unlikely to be that, then, there's lots of, again, different treatments. And that would, again, depend on what we think is the underlying cause and whether we think it's a drug-induced psychosis, in which case you might wait and see. And often people, as that drug kind of passes out, will improve. And if they don't, then you might want to think about an inpatient admission. Most people, particularly with this boy, you'd be thinking about an inpatient admission would be probably needed because he's sort of agitated and parents are a bit concerned about whether they could manage him. And you'd be wanting to then refer him to a kind of early intervention service who would have a lot more kind of psychological therapies available, and then thinking about an appropriate antipsychotic medication to help them if that was needed. And then kind of group work can also be quite useful around voices, and that's not necessarily just kind of kind of psychotic voices. Again, lots of people with pseudo hallucinations might go to groups with voices to allow them a bit more control over their experiences. So I think that's most of it. So I guess it was just about any questions really. I know it's a huge topic to cover, but I guess I just wanted to think about the huge variety of organic causes that there can be, and the importance of really thinking about those. And if there's any kind of concern or suggestion about it, then escalating to someone, a senior, a CAMS clinician, a neurologist, to kind of think about what investigations would be appropriate, because we don't want to miss something. Are there any questions? Because I've kind of whizzed through that, sorry. You're welcome. And I guess just to reiterate, the kind of COVID thing is very interesting, and it would be important for us to kind of not miss that, I guess.
Just with regards COVID, because I know with the inflammatory syndrome that they're seeing, young people are not necessarily having a positive test. So I had a young man who was sort of encephalopathic in his presentation, but had persistent negative tests, but it was still related to that. So I think COVID tests are definitely easy to do, but a negative result doesn't necessarily exclude things, which makes things really tricky.
Well, and I think that's all of this, you know, because also lots of the antibody tests will take a long time to come back. Exactly. You know, then that's why I think it's important to be talking it through with neurologists and psychiatrists, because it's relatively, you know, it's not, most of you won't see huge numbers of people presenting acutely psychotic. So it is about thinking, are we missing something, and should we be treating something or investigating further? And I think there's no problem asking. It's better to ask and escalate than to miss something. But and I guess I don't know whether they've done the antibody tests on people that presented with that, because that would be interesting, because although they might be negative on the tests, it'd be interesting to see if they've been positive on the antibody tests.
They have. At the Evelina, they've had a couple of kids who've been encephalopathic, and they're COVID negative, but when they've sent antibodies, they have been antibody positive, and there's a history of COVID in the family a few weeks ago. By definition, these kids are all COVID negative because it's an autoimmune type phenomenon. The latest thinking in PIMS.
Right, that's helpful to know.
Definitely an interesting one.
And I think my understanding is that Gosh and Evelina will probably be in London would be the two sites that would have the most experience of that, but I might be wrong. Does anyone else know? You know, just if you were going to escalate and have to ask someone, my assumption is those two would be the sites to ask in London.
The paediatric infectious diseases team at the Evelina have a hyperinflammatory on-call person at the moment.
There we go. Amazing. So that would be a good person.
Megan, can I ask a question about what are the kind of features in the history that would make you think more along the lines of functional psychosis? What are like the positive things that would make you think more along those lines, as opposed to make an organic cause like less likely?
Well, I guess looking at the kind of anti-NMDA red flags, you know, there's lots more of that kind of physical symptoms, you know, headache or loss of things or tremors, or so I suppose all of that stuff, or a significant past medical history of autoimmune aspects or family history, would make you think it's more likely to be you know, a kind of organic cause. It is very hard, because I think in history taking it can present, and I think certainly what you might have the symptoms, and then the physical symptoms come a bit later. So you might have the kind of hallucinations and change in behaviour often before I think the physical symptoms present in encephalopathy. So it's not always easy, and I think that's why we rely on a kind of team effort really with this, to kind of think about it, about what those. I mean, sometimes it would be very obvious if you've got this kind of fluctuation and it's more of a kind of delirium presentation, or there's clear physical cause, then that's sort of easier. But otherwise, it's kind of, I suppose, if they had every single first-rank symptom of psychosis, you might think, okay, well, it's much more likely to be that, and they have a strong family history of psychosis, that would be more helpful. But I would still, even so, I'd be wanting, you know, tests, because I just wouldn't want to miss, you know, an underlying cause, an underlying physical cause, I suppose. Anything else? Okay. Well, I'm really sorry about the technical error to begin with, but thank you very much, and I hope it was helpful. I'm not sure I would have told you anything that you don't already know, but I think it's just about escalating and involving teams of people, because it can be quite confusing and hard to know for definite. Right.
Thank you so much. That was fantastic. Just another plea on the kind of organisers' behalf to fill in the feedback, which will then be collated and sent to Megan. That would be really
it would be, because I can definitely change stuff.
I'm going it's at the top of the chat bar, but it's also on the spreadsheet with all the details as well. So thank you very much.
Great. All right. Thank you very much.
Thank you.
Bye.
Bye.